what's the indication for chest CT? I mean, there is a specific question about also pulmonary embolism protocol, Dr. Taoli, and they are also the related question: if the chest CT is negative but still clinically suspicious, what's the recommended time for follow-up study? So it's a question for it's multiple questions within the same question. Indication of chest CT. Would you do pulmonary embolism protocol? This was a question also. And if the chest CT is negative but still clinically suspicious, what's the recommended time for follow-up? So I think that's between Dr. Taoli and Dr. Siegel to answer.
Well, I can start very quick because I'm not the one requesting the chest CTs. Obviously, I'm on the other side. China, all the Chinese, centers have been doing a lot of chest CTs. So it's been really done, very frequently for pretty much all, the range of disease severity. That's why they came up with this huge series. And what happened here at Mount Sinai Health System, it's a little complicated, but basically we have peripheral satellite hospitals, and we have the main Mount Sinai hospital. So peripheral hospitals initially, they started doing a lot of chest CTs, and as opposed to the main campus where we follow the rules saying that you shouldn't use chest CT for screening. So we had this discrepancy initially where we had tons of chest CTs from Queens, from Brooklyn, but very few from the main hospital, and then eventually kind of evened out, and now we had much less chest CTs. I think we had something like maybe 400 chest CTs done for over 2,000 patients. So that tells you that chest X-ray has been used much more often than chest CT. But obviously, if there's a complication suspected, we do a chest CT, but just for diagnosis, we try to avoid it as much as possible, for diagnosis. Now, PE studies, only if it's suspected, mostly due to based on the dimers, I would say. However, I'm going to let Keith answer that question because I'm not sure, because the dimers can be elevated also in infection. So I'm not sure what's the value of that clinically. And the last question, if the chest CT is negative, I think really important to look at the clinical picture. If the patient is really doing fine, I would let them go home. Don't do repeat study. If the patient is not doing so, clinically so well, then maybe repeat the CT within 72 hours. That's my, recommendation. Maybe Keith, you want to answer some of it also?
Yeah, I would say, a CT scan is really, a CT without contrast is really only going to be something that we're going to want if we have some suspicion that something other than COVID could be superimposed or going on at the same time. So if there's concern of bacterial superinfection or even empyema, if things just don't seem like a typical COVID case. And with the CT angiogram, again, I mean, in severe cases, we need to have a much higher suspicion because we know that we're seeing them a lot more frequently. So I would say you have to balance the risk of contrast, associated complications with, if you have any suspicion for a PE, then it's something worth considering. And again, follow-up studies, I'm not even sure what the role of them is unless you find something that's not COVID. I would rely for COVID, or for SARS-CoV-2, I would rely on PCR testing and not imaging.
Thank you very much, Dr. Taoli and Dr. Siegel.